Okay, good morning everyone. Today we are going to continue with our book club on the fundamentals of diagnostic radiology. We have stopped for like a month due to the exams. Now we will continue from where we stopped with Dr. Ban. She will present the chapter on the abdominal arteries, venous system, and non-vascular interventions.
Good morning. Abdominal artery, venous system, and non-vascular intervention. Abdominal aorta and its branch, abdominal aortography and intervention, renal angiography and intervention, splenic angiography and intervention, hepatic angiography and mesenteric angiography. Abdominal aortography and intervention, most often performed for atherosclerotic disease, both aneurysmal and occlusive aortic dissection, trauma. Rare causes include vasculitis like Takayasa arthritis and mid-aortic syndrome. Abdominal aortic aneurysm etiology, atherosclerosis, the most common cause, infection, mycotic. Abdominal aortic aneurysm defined as an enlargement of the aorta more than 1.5 times greater than the normal vessel diameter. Although ultrasound can demonstrate the aneurysm and be used for screening and surveillance, CT has become the diagnostic study of choice. Aneurysm screening is recommended for men with history of smoking and over the age of 65. If there is a family history, screening should be started at 60. Angiography demonstrates only the true lumen, not the portion of the aneurysm which is the thrombus field. This results in underestimation of the aneurysm diameter. This limitation, the advance of CT angiography and potential risk associated with angiography has resulted in the reduction in its use. The risk of aneurysm rupture increases with increasing diameter. Treatment is recommended for aneurysm which is greater than 5 cm or abdominal aortic aneurysm expansion greater than 5 mm in 6 months. Treatment option, either open surgical repair or stent graft replacement, which has become widely accepted due to its minimal invasiveness. One of the major concerns with the placement of the endograft is the continued filling of opacification of the abdominal aortic aneurysm following stent graft placement, termed as endoleak. Such leaks are best studied with CT as well as by angiography, particularly as endovascular techniques are utilized to repair such leak. This is an example of infrarenal abdominal aortic aneurysm, and the second picture for stent graft below the renal artery extending into both iliac artery.
So you can see here when angiography you underestimate the aneurysm. An aneurysm could be this big, all of this is thrombus. You see only the lumen, so it's underestimation. You correct pictures with CT, not with angio. First. Second, when you put the stent graft, they have to be sure that there is no contrast going into the aneurysm, because this means endoleak, يعني ما سويتش, you have done nothing. Okay? So endoleaks are different types. I'm sure you've read it, type 1, type 2, type 3. Okay?
Types of endoleak. Type 1 is the leak at the superior or inferior attachment site. Type 2 represent abdominal aortic filling via a patient arterial side branch such as lumbar or inferior mesenteric artery. Type 3 is the loss of integrity of a stent graft. Type 4 is leak through the porous graft material. Mycotic aneurysm or pseudoaneurysm of the abdominal aorta are rare but life-threatening condition and are often surgical emergency. Radiologically, they often appear circular and very irregular. Their rate of growth and the patient constitution symptoms suggest the infectious nature. The commonest pathogen is Salmonella species, accounting for incidence of up to 74%. Aortoiliac occlusive disease is most commonly caused by atherosclerosis, can occur also from inflammatory disease, in particular Takayasa arthritis. Patients with aortoiliac disease usually present with claudication, the most dramatic example termed as Risch syndrome, which is the combination of bilateral robotic claudication, impotence, and absence of femoral pulse. This is typically associated with occlusion of the infra-abdominal aorta. Radiographically, atherosclerotic involvement of of the distal aorta and iliac artery is identical to elsewhere with plaque formation, calcification, and visual narrowing. Aorto-iliac occlusive disease is properly best initially approached with endovascular technique, including angioplasty with or without stent placement. Picture A show pelvic angiogram in 55 years old female with severe claudication demonstrates severe aortic and bilateral proximal common iliac artery atherosclerotic disease. B show angioplasty with kissing stent extending from the common iliac artery into the aorta.
You can see the two common iliacs extremely narrowed with multiple collaterals bypassing the stenosis, indicating Large syndrome. And here they put two stents, kissing stents, to open them.
Abdominal aortic dissection is almost always associated with, or in fact is an extension of thoracic dissection. Abdominal aortic dissection are best imaged by CT, although MR does provide excellent diagnostic image. CT demonstrates both lumen, how well they fill with contrast material, the proximal and distal extent of dissection, as well as the patency and relationship of branch vessel to the dissection. Besides rupture, of greatest importance is how the dissection plan affect the abdominal aortic branch vessel, including visceral, renal, aortic bifurcation. Angiography is usually reserved for symptomatic patients prior to intervention. The emergency of a number of endovascular techniques has significantly impacted the management of patients with aortic dissection. Endovascular technique includes stent grafting for the entry site, the origin of the dissection, a closure to prevent an aneurysmal widening of false lumen, balloon fenestration of the intimal flap, and aortic true lumen stenting to alleviate branch vessel ischemia. This show dissection of axial image show dissection flap separating true and false lumen. B show oblique sagittal reformate which show thoracic stent graft with true and false lumen. C show axial CT image after stent graft placement with the true lumen and extending the false lumen.
See what's happening here? They put the stent graft at the origin of the dissection at the beginning حتى يسد الفتحة حتى blood لا يفوت للفورس لومن يصير ثرومبوسيس وخلاص انتهى الموضوع. other approach إذا أكو ischemia مثلا إذا هنا renal artery طالع فرضا منه if the renal artery is going here so if they included this there will be renal ischemia. هذا الفورس لومن ما راح يفوت blood راح يصير renal ischemia. مثلا شو يسوون؟ الواير نفسه فورته بالعكس فورت هو طرف لين وطرف قوي واير جايد واير they put the hard end in and they just make holes here يصرفوها هذه يصير البلد يفوت ويطلع كأنه يصير بارت من الترولومن تقريبا فيفوت البلد للكدني للفولس لومن وبنفس الوقت ما يصير ما يزيد الدايسكشن it will not extend لأنه the pressure will be equal between here and here. حطوا فتحات منه بس الانتيمال فلابي they make a holes in it fenestration حتى تصير كلها كأنه لومن واحد.
يعني حتى هو الديسكشن يعني يصير قسمين.
Intimal flap separates from the wall. Okay. راح يصير هنا false lumen. blood يفوت ما يطلع.
شلون يعرفون الترولومن يعني فلاب هو اللي
فلاب بالضبط. فالبلاد يفوت ما يطلع اوكي من يفوت هنا راح يزيد الدايسكشن ينزل لي جوا اكثر فكل اللي يحتاجه بس يعادل الضغط بين هاي وهاي انه يفتح فتحات هنا فالبلاد يفوت ويطلع that's simple as that.
هذا الفنستريشن prevent
progression and prevent ischemia of the vessels arising from the false lumen.
Trauma. Patient rarely survive abdominal aortic trauma, but pelvic trauma resulting in significant bleeding is more commonly seen. Bleeding associated with pelvic fracture may be controlled by fixation device for those who cannot routinely come to angiography for imaging and chemo and embolotherapy. Arterial bleeding is most often associated with injury to one or more branch of the internal iliac artery and is often demonstrated on CT during trauma evaluation. Embolization is often performed with a proximal agent such as gelatin sponge if a temporary agent is desired, or coil for more permanent occlusion. Bleeding associated with pelvic fracture can be effectively controlled with embolotherapy. This example shows traumatic hemorrhage in the pelvis with the embolization of the superior gluteal artery was performed with coil. Renal This is the hemorrhage from the branch of superior gluteal artery,
Okay.
and at this site, so-called
Some embolic agent,
embolization.
and after injection,
And hemorrhage control.
No bleeding. The fracture is evident.
Renal angiography and intervention. Single renal artery occur approximately 60% of time, with either multiple artery or an early renal artery division is seen in other 40%. The most common reason to study renal artery is for occlusive disease, trauma, less often for other abnormalities such as neoplasm. Imaging of renal artery include ultrasound, CT, MR, with nuclear scintigraphy also playing a role in the relative perfusion of the kidney. Renal angiography remains the gold standard once screening suggests an abnormality. Angiography not only provides diagnostic image, but endovascular therapy can be applied in same setting and is often the primary goal for the angiographic procedure. Renal artery are often studied in patients with decreased renal function. In such patients, alternative image, not require identity contrast, is recommended, but when angiography is required, there are several useful options. Alternative contrast agents such as carbon dioxide have been successfully used, particularly in conjunction with a small dose of iodinated contrast. Alternatively, traditional low or isoosmolar iodinated contrast material may be used and kept to minimum, especially if the patient has received the prevention therapy. Chief among this is the hydration, which is the most currently the only proven renal protective maneuver. Etiology for renal artery occlusion. The two most common causes by far are atherosclerosis and fibromuscular dysplasia, account for 99%. Other causes include dissection, vasospasm, vasculitis, coarctation, etc. Fibromuscular dysplasia is the most common cause of renovascular hypertension in patients younger than 40 years. Three main types based on the morphological appearance and layer of the involved artery wall. Intimal, 7 to 8%, medial, which is the most common, 85%, and peri-arterial, 7 to 8%. Medial fibromuscular dysplasia account for the majority of the cases and has a classical string of bead appearance on angiography, which represent alternative web like stenosis and aneurysm. The middle and distal main artery, renal artery, is the most frequently involved. Fibromuscular dysplasia is the most common cause of the hypertension in children. Fibromuscular dysplasia classically respond well to angioplasty alone, with success rate approaching 98%. Stenting is rarely required unless there is a dissection resulting from the angioplasty. This example of fibromuscular disease of the right renal artery shows the classical string beaded appearance. Atherosclerosis renal occlusive disease. Atherosclerotic renal occlusive disease clinically present with hypertension, renal failure, or both. Patients with atherosclerotic renal disease are usually over the age of 60. Atherosclerotic renal disease, renal artery stenosis, is amenable to angioplasty, but is not as straightforward as simply dilating the region. Anatomically, the atherosclerotic renal artery region is in the proximal renal artery and the aorta. The latter is rarely responsive to angioplasty. Stenting of the renal atherosclerotic lesion for the most part overcome this, and it is the standard. But despite an anatomical successful procedure, the patient may not respond very well. In fact, greater than 95% of patients have essential hypertension, and the etiology of the renal insufficiency is often multifactorial. The result of renal angioplasty are often reported as cured of all antihypertensive medication or improve if require significantly less medication or failed if no change or worse by treatment.
يعني عندنا ال FMD fibromuscular disease or dysplasia young present with hypertension due to the FMD بس يحطون بالون بينفخوا angioplasty that's it cure 98% cure okay more common in females. Aneurysclerotic elderly usually they have hypertension primary not due to the atherosclerosis or it's a multifactorial من جهة atherosclerotic من جهة kidney من جهة age من جهة cardiac all of so they put balloon dilate nothing they have atherosclerotic artery heart قوي okay so they put a stent okay ودايليت وحتى ورا هذا no ممكن improve أو not
improve atherosclerotic renal artery stenosis aortogram in 68 years woman with hypertension show bilateral renal artery stenosis following angioplasty significant dissection flap is noted. This is the dissection flap following angioplasty. See aortogram following placement of balloon expandable stent show excellent radiographic results. This renal transplant artery narrowing most often due to surgical technique factor acutely or intimal hyperplasia at the anastomotic site late or even from atherosclerosis much later, all of which may be amenable to balloon angioplasty with or without stenting. Renal artery aneurysm are of two types: extrarenal due to aneurysm are of two types: extrarenal due to atherosclerosis or fibromuscular dysplasia, and multiple small aneurysm, microaneurysm, within the kidney associated with polyarteritis nodosa. The differential diagnosis of microaneurysm include polyarteritis nodosa, Wegener, granulomatosis, SLE, rheumatoid, and drug abuse. Renal neoplasm. Angiography for renal neoplasm is rare. However, it may be indicated for preoperative embolization prior to surgical resection or palliative for hematuria. Renal cell carcinoma and angiomyolipoma can be hypervascular, but definitive diagnosis cannot be made angiographically. Renal trauma. Penetrating or major blunt trauma, a full range of injury can be encountered from hematuria without visible injury to shattered kidney or renal hilum avulsion. Angiography is most often performed in these patients to confirm the extent of injury or to perform endovascular treatment of injury if possible. Iatrogenic trauma to the kidney from biopsy or catheter replacement can be occur. Most of these injury sites are amenable to endovascular treatment, most often by subselective catheterization and coiling. Splenic angiography and intervention. Indication for splenic arteriogram and intervention. First of all, trauma is the commonest indication for splenic arteriogram and endovascular intervention. In the hemodynamically stable patient, the risk for delay rupture increases with the severity of splenic injury. When acute extravasation or avascular abnormality such as pseudoaneurysm or fistula is discovered, subselective arteriography and embolization of the branch involved are performed. Coil are preferred for embolization for the main splenic artery or its branch. This example for splenic trauma, a splenic angiogram demonstrates diffuse injury of the spleen with multiple areas of extravasation. B show occlusion of the splenic artery following embolization with coil.
هو أهم شيء المين source of bleeding to be occluded. إذا صار infarction big part of the spleen that is supplied, okay, you start bleeding. If there is enough collaterals to supply the spleen, مثل ما جماعة السبلينكتوم إذا عنده سبلينيو بتقول إن the same idea. إذا ضل هدد راح يكبر وراح يرجع مو مشكلة. Don't worry.
During the angiography, ولما يخلون الكويل.
إيه.
شو بيسوي يعني examination to see it is يعني لحظتها.
the same minute نفس السكند they put the coil and then they inject. لازم يكون complete occlusion. إذا ظل يعبر كونتراست ما نقدر شو نسوي. يظل يحط كويلات إلى ما يصير تماما.
يعني فولو اب ما يحتاج بنفس الوقت.
لا سيم سكند.
Hyperspleninism.
ياخذ دوز هاي من الراديشن.
هو سبلينك انجري وبليدنج باقي له دقائق بدون
Hyperspleninism, anemia, thrombocytopenia, splenomegaly causing discomfort, and gastric varices due to splenic vein thrombosis are indication for partial splenic infarction. Embolization is performed with distal agents such as gelatin sponge. It is imperative that the catheter be distal to the pancreatic branch prior to the infusion of the embolic agent to prevent pancreatitis. Splenic artery aneurysm is the most common aneurysm outside of the aorta and iliac artery, most common in female. Congenital aneurysm has higher rate of rupture. The diagnosis is typically made with CT or MR. Can be treated with coil obliteration, trapping of the arterial segment with coil or detachable plug. Complications include dissection or vascular injury specific to spleen, pancreatitis, and splenic infarction with abscess formation. Patient should be given pneumococcal vaccine prior to the procedure when time allow. This example for splenic artery pseudoaneurysm, celiac angiogram demonstrates large pseudoaneurysm.
So you can see here this is a big aneurysm arising from the splenic artery. What is the neck of the aneurysm? Can you show it to us?
This is the neck.
So this is the neck arising from the splenic artery. Okay.
Following
طبعا
coil.
good thing here it's a narrow neck. Narrow neck is good for embolization.
الابدومينال اورتا لارج نيك
Splenic. This is splenic aneurysm. narrow neck مثل الانتراكرينال نفس الفكره. من يكون narrow neck الكويل راح يثبت بمكانه. It's easier to حطوا له coils بالnext image.
for abdominal aortic aneurysm.
Abdominal aortic aneurysm is a fusiform. هي كلها neck.
This after coil show the still remain show the neck of the aneurysm. Hepatic angiography and intervention. First, trauma. In the setting of blunt or penetrating trauma, hepatic arteriography is used to evaluate for vascular injury in patients with abdominal CT or ultrasound. Typically, embolization is indicated in hemodynamically stable patient with hepatic arterial injury and evidence of bleeding, or in patient that present with a delayed complication from conservative management of liver laceration. Iatrogenic injury from biopsy or percutaneous cholangiography with or without drainage occur and can be resolved with endovascular treatment. Indication for embolization in the acute setting include continued hemodynamic instability, arterioportal fistula, and hemophilia. In delay setting, C2 aneurysm discovered on CT or ultrasound carry 44% risk of rupture and may require emergent management. This is a CT scan show during the arterial phase of enhancement show enhanced hepatic artery and simultaneous arterial density contrast within the portal vein. A hepatic perfusion abnormality is evidence. B show selective hepatic arteriogram, which show a branch of right hepatic artery leading to a fistula resulting in the filling of portal vein branch.
Where?
This is the hepatic. This is the early filling of the portal of the hepatic. Sorry, of the hepatic vein, and this is the because the same the same density in the arterial vein يعني closer density. Density of the density يعني closer to the density.
First, you have the timing of the injection. Second, you can see here hepatic arteries are dense. Indicating it's an arterial phase. Okay, but if it's arterial phase, why the veins are showing?
The veins show.
The contrast. There is something wrong. Contrast major artery vein at the same time.
Yes.
Okay. So after when they do angiography, they can see a fistula between the artery and the vein. Okay. So they just go in, occlude this fistula, and that's it. Okay? Just a second. Okay, so مثل ما قلنا حطوا الكويل after that injection best arterial no venous. Okay? Yeah. Continue.
Neoplasm are diagnosed by CT, MRI, and ultrasound. Angiography is performed to determine resectability, to provide an arterial roadmap, and to deliver transcatheter therapy such as embolization. Capillary hemangioma demonstrate uniform dense stain in the late arterial phase, which persist beyond the venous phase. They are usually well defined but irregular border with a feeding artery which is near normal in size. Cavernous hemangioma have the classical appearance of contrast puddles near the periphery in well-marginated vascular space. While the stem persists beyond the venous phase, the lesion may be up to 15 centimeter in size, and feeding artery is usually normal in size. Hepatocellular carcinoma demonstrate hypervascular mass with large distorted feeding artery, neovascularity, and intratumoral puddling of contrast, and portal vein invasion with arterioportal shunting may be demonstrated. Up to 25% of tumor are hypovascular. The combination of portal venous invasion and arterioportal shunting is virtually pathognomonic for hepatocellular carcinoma. Cholangiocarcinoma, usually hypovascular or avascular tumor without neovascularity. Metastasis, the degree of vascularity and staining on angiography has a little relation to the tumor blood flow. Even with hypovascular metastasis, the blood flow is increased relatively to normal liver parenchyma. Angiography may show displacement of the adjacent vessel and compressed or occluded portal vein. Arterial encasement or shunting is rare. Embolization of metastasis has mixed result. Hypervascular metastases include neuroendocrine tumor, renal cell carcinoma, thyroid, and choriocarcinoma. Hypovascular metastases include lung, esophagus, pancreas, pancreatic carcinoma. Mixed vascularity is seen in breast, ocular carcinoma, cholangiocarcinoma, and sarcoma. Embolization. The decision to embolize the lesion involves a number of important points. First, is the portal vein patent and what direction is it flowing? Portal venous flow is needed to preserve the functional hepatocyte in distribution planned for embolization. Embolization of the hepatic artery is usually well tolerated if the portal venous flow is available. Portal venous thrombosis or hepatofocal flow increase the risk of hepatic infarction and failure. Embolization can be done in setting of portal vein occlusion if a modified low-dose super-selective technique is used. Second, if we are embolizing a tumor which are responsive to embolization, including hepatocellular carcinoma, neuroendocrine tumor, melanoma, sarcoma, and colorectal metastasis. Tumor replacement of greater than 50 to 75% of normal liver is a contraindication to embolization. Chemoembolization are usually performed with a mix of thiazide oil and cytotoxic agent in addition to the particle. Finally, the trauma. Proximal agents are the theme in the treatment of the hepatic arterial injury. Coil embolization of the vascular injury should be performed as selective as possible to avoid complications including abscess formation, ischemia, and biliary stricture. Delayed complications include pseudoaneurysm, fistula, and hemophilia. These can be treated with microcatheter, subselective embolization, the source vessel, give the end arterial characterization of the liver, and lack of collateral supply. This example showing a tumor embolization. Celiac arteriogram demonstrates hypervascular mass in the right hepatic lobe in patient with metastatic carcinoid. B. After completion arteriogram following embolization with particle demonstrate absent enhancement of the mass, and this is the enhancement before the embolization, and after embolization no enhancement of the mass. Indication in liver transplantation. The initial planning of the transplant may be impacted by variant arterial anatomy, which is primarily evaluated with CT and MR angiography. In the event there are question, angiography remain the gold standard. Arterial anastomotic stenosis can be treated with angioplasty and stent placement. Iatrogenic injury from biopsy or biliary drainage can be evaluated and treated endovascularly if needed. Splenic arterial steal. This is involved hepatic arterial ischemia in the setting of splenic arterial and portal venous hyperperfusion. This is liver transplant. Celiac arteriogram reveal high grade at the hepatic artery anastomosis stenosis in patient post liver transplant. B. Balloon show the row is in the place setting the stenosis. C. After completion angiogram demonstrate resolution of the stenosis. This is the stenosis.
The stenosis and the balloon in the middle.
This
They just inflate the balloon
and
complete.
Mesenteric angiography and intervention. The celiac, superior mesenteric, and inferior mesenteric artery are the main arterial supply to the GIT. Indication: gastrointestinal hemorrhage is the most common reason to perform angiography of the mesenteric vessel. The evaluation of GIT bleeding include nasogastric tube aspirate, esophagogastric duodenoscope, colonoscopic, and radionuclide imaging, tagged RBC and sulfur colloid, and angiography. Hemodynamically unstable patient may require emergency angiography and or surgery, while the stable patient is able to undergo a more controlled systemic evaluation and treatment. Upper GIT hemorrhage is typically suspected in the setting of positive gastric aspirate and melanotic stool. Endoscopic evaluation and intervention is the first-line therapy. It can be directly treat the lesion or direct endovascular intervention when there is no angiographic evidence of bleeding. A lesion within the duodenum is typically managed with embolization of the gastroduodenal artery. Gastric ulceration is treated with right or more typically left gastric arterial embolization. The technical success of embolization for upper GIT bleeding is greater than 90%. While the clinical success rate range between 75 and 90%, proximal agents such as coil and gel form are preferred. Lower GIT hemorrhage, colonic diverticuli, the most common cause. Unlike upper GIT bleeding, in the lower GIT bleeding there is a limited role for initial endoscopy. Typically, the patients are evaluated with the nuclear scintigraphy followed by diagnostic angiography with super-selective embolization if a bleeding site is located. The most reliable angiographic sign of GIT bleeding is contrast extravasation, which is seen as an amorphous contrast collection that persists through the venous phase. The pseudo-vein sign is a linear collection of the contrast between a mucosal fold that simulate an enlarged vein. Bleeding must occur at rate of at least half cc per minute to be identified by angiography. Although diverticula are much more common on the left colon, bleeding diverticulum is 3 times more common to be found in the right colon. This is an example for lower GIT hemorrhage. Radionuclide tagged red cell scan demonstrate abnormal collection of radio tracer within the right side colon. Selective injection of superior mesenteric artery with abnormal extravasation in the ascending colon and abnormal collection of the contrast. Described as a pseudo vein. Following coil embolization, no further bleeding is evident on completion angiogram. Angiodysplasia show the classical angiographic feature of early opacification of an enlarged draining vein, persistent dense opacification of the vein, and vascular tuft along the antimesenteric border of the cecum or ascending colon. Tumor usually causes slow bleeding and anemia, but infrequently the source of massive lower GIT bleeding. Treatment of colonic bleeding has shifted toward the upper superselective embolization with coil or particle. if the catheter can be advanced into the arcuate branch of the colon, collateral flow to the segment of bowel is preserved. This is thought to decrease the risk of infarction. Mesenteric ischemia comprise a group of disorders that have common endpoint of bowel necrosis. Mortality rate approach 70%. Mesenteric ischemia can be divided into acute or chronic. Arterial embolization and thrombosis, non-occlusive ischemia, and mesenteric venous thrombosis are cause of acute mesenteric ischemia. Embolism and thrombosis account for approximately 75% of acute ischemic episodes. In the embolic cases, which is most commonly cardiac in origin, the arteriograph appearance is of an abrupt cut off superior mesenteric artery at site of its most proximal branch, typically 4 to 6 cm from its origin. Has a reverse meniscus appearance due to the contrast partially enveloping the embolus, which has lodged at the branch point of superior mesenteric artery. Arterial thrombosis occur on background of pre-existing severe atherosclerotic occlusive disease of the celiac and superior mesenteric artery. Intra-arterial infusion with a thrombolytic such as TPA allow for the dissolution of the clot and subsequent intervention on the underlying vascular regions such as osteostenosis. Surgical intervention may be needed if the bowel infarction is present. This is example for mesenteric ischemia. Superior mesenteric aortogram demonstrate high-grade proximal stenosis of superior mesenteric artery. And this is the stenosis of superior mesenteric artery. An angiography balloon mounted stent used to treat the stenosis. Complete angiograph demonstrates stent and complete resolution of the stenosis. Non-occlusive ischemia account for approximately 10% of acute ischemia. Low flow state angiography confirm diffuse vasoconstriction without underlying structural abnormality, sausage link narrowing. Mesenteric venous occlusion generally affect the medium-sized vein of the middle small bowel and account for about 10% of cases. This can be treated with catheter-directed thrombolysis. Both mesenteric venous thrombosis and non-occlusive ischemia can present with GIT bleeding. Chronic mesenteric ischemia occur with occlusion or high-grade stenosis of at least 2 of the 3 mesenteric arteries. Etiology include atherosclerosis, fibromuscular dysplasia, and various vasculitis. Patient typically present with a postprandial pain. The treatment angioplasty and stenting or surgical bypass. Diagnosis and intervention of the venous system. Venous access. Central venous access catheter can be categorized as temporary, non-tunneled, tunneled, and implantable. The indication for replacement of this catheter include assist for antibiotic therapy, chemotherapy, parenteral nutrition, pain management, and hemodialysis. Non-tunneled, they can be used to assess for up to 4 weeks. Inserted through the peripheral upper extremity vein like brachial cephalic vein, allow for central placement of the catheter tip at the cave arterial junction to reduce the risk of subclavian venous thrombosis.
tunnel هو نفس السنترال فينوس لاين اللي هو very short period. التنل يحفرون جوا السكن هنا تحت السكن. They put it the catheter and then the tip goes into the superior cava or right atrium. Okay, implantable for more permanent drainage. Next. The filters they put in the inferior vena cava, preferably lower than the renal vein, level of the renal vein. But if cannot be done due to any reason, then they put suprarenal. Most of the filters يحاولون يحطوها انه retrievable حتى بعدين they retrieve it يعني يرجع نورمال. اوكي، فكل الايديا انه الفلتر يعني اذا اكو ثرومبس مثلا هنا هذا filling defect. اوكي، they put the filter there وتشوفون بيه هوك حتى يفوت من الانترنال جاجولار بعدين مثل الشلاب ويسحبه. اوكي، يلا نيكست.
Superior vena cava occlusion. Most common tumor we treated by يعني mostly by radiation or stenting.
Like
This example for superior vena cava
you
obstruction.
can see here contrast best up. It's not going into the heart due to SBC obstruction.
But the Chiari syndrome,
Chiari syndrome thrombosis of the hepatic
hepatic
vein.
vein.
Okay, one hepatic vein مثل three hepatic veins. One process full syndrome. Okay.
show a characteristic spider web pattern of the collateral vein.
وطبعا يصير العلاج بالكوديكلو لانه الكوديكلو has a separate venous drainage. Like here you can see the spider web appearance, obvious. Okay. What should we
Venogram of the infrahepatic inferior vena cava show
inferior
mass
vena
effect. Mass effect of
It's a
the
compression على
hepatic
IVC
congestion
due to
on the IVC.
congestion of the liver. tips ببساطة من اكو portal venous hypertension نريد نشيل الهايبرتنشن فيفوتون intratransjugular طبعا it's a highly specialized interventional procedure يعني مو اي واحد يعني كلش ذاك من ذاك يشتغل يفوتون transjugular into the IVC into the heart to the IVC بالIVC يفوت بالهيباتيك فين من الهيباتيك فين يحفر بالليفر يحفر بالحرف يعني يحفر نفق الى البورتال فين ويحط الستنت هناك فيصير البلد يجي من البورتال يفوت قبل الIVC باي باسنج ذا ليفر حتى شنو تقل البورتال هايبرتنشن بس طبعا impairing liver function يصير hepatic encephalopathy كل شغل بس يعني just to relieve symptoms okay like here you can see هاي حطوا الستنت you can see here stand بين البورتال فين والIVC الهيباتيك فين يعني to relieve obstruction. يلا next. شنو هو؟
The complication of tips.
Non-vascular intervention
Percutaneous nephrostomy.
You can ما ادري شايفينها اذا اي حد يشتغل ويا جماعه البوليه وايد يمر عنهم. Any case that cannot the renal collecting system cannot be drained by a double J stent or for any reason, then we can do a percutaneous nephrostomy. Then we just by ultrasound localize the pelvic calyceal system, preferably the lower calyces. You go under ultrasound the lower posterior to away from the pleura. Okay. You go by under ultrasound guidance, puncture the calyceal system, put a pigtail catheter there, leave it for drainage.
And this is an example for
This is
percutaneous.
a nephrostomy.
For how long it will remain?
As long as you like. يعني you can exchange it إذا صارت ورا فترة وما راح الأوبستراكشن. Okay. بس ورا 3 months حتى ورا 3 months. You can just exchange the catheter. حط guide wire, change catheter بالقديم, you put the new catheter. That's. Yeah. هذا نسوي anastomosis صاير بي ناوي بالنفروستومي. شو قاعدنا؟ biliary drainage, percutaneous. الكوليسيستوستومي I've done it like 2-3 times. Very successful procedure. Amazing يعني relief للpatient immediate.
ترتمط طبعا.
لا مش بس. You just like in nephrostomy. Someone has an acute cholecystitis that cannot be operated for any reason. And the cardiac problem, and the CVA, and the diabetes, المخدر ما يقبل التخدير، الجراح ما يقبل البيلة, whatever. Under local anesthesia, you go puncture the gallbladder, you put the draining catheter there, you leave it. Okay? راح يصير drainage للbiliary البايل. Okay? Deflate the gallbladder, you leave the catheter there for a while حتى يصير maturation للtract, and then you remove it. The trick بالموضوع you go through the liver. يعني تفوت لازم بالليفر تزرع في الجولبلادر مو تفوت من الابدومين لانه هو بالبانكشر مالتك راح يصير ليك للابدومين بينما اذا بالضبط بينما اذا تفوت بالليفر ما يصير ليك. Okay? I've done 2-3 cases and they just continue their life without cholecystectomy.
You will inject saline for
اول شيء راح يكون distended under pressure بس تسوي لها بانكشر راح يطلع بايورس. ورا فترة يجي بس فور كلينيك شوية صناعي تسحب نظف وتخليه تمام. بعد شو قالنا؟ And that's it. Thank you.